Okay, I'll be talking about how we use iPSC-derived cardiomyocytes to find new treatment targets for heart failure. So we all know that heart failure is one of the leading causes of death and disability, and in Singapore, it's one of the leading causes of hospitalization. And of course, new treatments are needed to prevent the onset and progression of heart failure. And we're all aware of the FDA Modernization Act 2.0, which suggests that we should be moving more towards human models for drug discovery. So it's not obligatory or not necessary to test your therapy in terms of efficacy using animal models, but you could use more human models. And in our lab, like others, we make iPSCs from patients' blood sample from the PBMCs, and we differentiate these into cardiomyocytes. And then we use this to model different cardiac diseases to find new treatment targets, but can also use it to screen other therapies. So I'll talk on two conditions. First is hypertrophic cardiomyopathy. This is, of course, an inherited cardiomyopathy which lends itself perfectly to iPSC-derived cardiomyocytes because of monogenic mutation. I will talk about mitochondria as a potential treatment target. Then I'll move to HFpEF. Of course, HFpEF increasing in prevalence in Asia and worldwide, especially with our increased age expectancy and increased CVD risk factors. And I'll show how we use iPSC cardiomyocytes to model HFpEF. And we use this platform to look into the cardioprotective effects of SGLT2 therapy. So I think you all know that HCM, familial condition, prevalence of 1 in 500, commonest cause of cardiac death in adolescents, young adults, and athletes. And it's characterized by increased wall thickening, cardiomyocyte hypertrophy, disarrayed myofibers, and interstitial fibrosis. And this leads to impaired left ventricular relaxation and diastolic dysfunction. And so we've, like others, we've modeled HOCM in iPSC cardiomyocytes, and here you can see two different patients who have HOCM of binding C3 protein and MHCM7 with HOCM, and you can see that there's cellular hypertrophy. And when we look at the calcium handling using calcium transients as well as contractility, as expected, there's impaired calcium handling and impaired relaxation. So using this platform, we can interrogate this to find defects in metabolism and also see if we can find new treatment targets. So we're very interested in mitochondria. Of course, metabolic defects underlie or contribute to the calcium disturbance and hypertrophy of HOCM. So we looked at doing seahorse studies of mitochondrial respiration in the iPSC cardiomyocyte. So you can see compared to the healthy controls, there is impaired mitochondrial respiration in the HOCM iPSC cardiomyocytes. And then when we do metabolomics in these iPSC cardiomyocytes, you can see in red and green that there's a reduction in the fatty acids. In these HOCM iPSC cardiomyocytes, they switch from fatty acid to shorter chain acylcarnitines. We were wondering whether this metabolic change in substrates is accompanied by changes in mitochondrial morphology. As you know, mitochondria are able to change between fission and fusion, and fatty acid metabolism is associated with more filamentous or elongated mitochondrial morphology. So our first step was to look at the mitochondrial morphology in the HOCM iPSC cardiomyocytes versus control. And interestingly, we found they're more fragmented or have more fission. And mitochondrial fission and fusion are governed by the fission and fusion proteins, and one of these is DRP1. And this DRP protein sits in the cytosol, and in response to stress stimulus, it will go to the mitochondria. And what governs its translocation is phosphorylation at the 637 site. So if DRP is phosphorylated at 637, then it's in the cytosol. But if there's a stimulus to make it go to the mitochondria to cause fragmentation, then you get a reduction in this phosphorylation site. So interestingly, we found in the HOCM iPSC cardiomyocytes there is less phosphorylation or DRP1, and this could explain in part the mitochondrial fragmentation we see as well as a shift in substrate utilization. So then we tried to correct this. We used MDIV1. This is a small molecule inhibitor of DRP to see if we could correct the metabolic and the functional defect in these HOCM cells. So we found that when we treat with MDIV1, this is to inhibit DRP fission, we find that we can speed up reduce the contraction time and reduce the relaxation time. And these findings on the function were associated with improvements in mitochondrial respiration in terms of ATP production, as well as increased mitochondrial respiration. So it seems that by targeting metabolism in these HOCM iPSC cardiomyocytes, you are able to improve the relaxation And we're now planning to test this therapeutic effect in vivo using a hokum mouse model. So this is quite interesting because, as you know, mavacamten, these target myosin chains that inhibit myosin function to improve relaxation. This could be an alternative approach to treating our patients with hokum. So now moving on to HFpEF. This is an interesting study to model because usually iPSC cardiomyocytes are confined to monogenic mutations, whether it's non-QT syndrome, ARVC, DCM, or HOCM, but we wanted to see whether we could actually model a polygenic condition like diabetic heart failure. So we made iPSC cardiomyocytes from 9 patients, 3 healthy, 3 patients with diabetes and heart failure, and 3 patients with diabetes, no heart failure. And you can see the age distribution here. We tried to choose relatively young patients because we wanted those that may have an epigenetic or genetic component. We chose all Chinese, and you can see our diabetic heart failure and diabetic patients were obese. And they were the primary defect was HFpEF in our diabetic heart failure patient. And in our diabetic patient with no heart failure, function was normal, no diastolic dysfunction. And we tried to choose those patients with relatively few comorbidities because we really wanted to see if there was a genetic component that could be transferred to the iPSC cardiomyocytes. So from PBMCs, from these patients, these 9 patients, we made iPSCs and cardiomyocytes. And then we did structural and functional phenotyping. So this is showing the iPSC cardiomyocytes in size. You can see the diabetic heart failure ones has a larger cell size, and the diabetic one with no heart failure has a slightly increased in cell size, more than a healthy, but not as much as a diabetic and heart failure. And we look at calcium transients, we can find, again, similarly, there is a defect in a diabetic heart failure with impaired calcium transients, also impaired relaxation, and the diabetic without the heart failure seems to have a milder phenotype. So this seems to suggest that these diabetic iPSC cardiomyocytes, especially those from the HFpEF patient, seem to have a phenotype that recapitulates the clinical phenotype that we see in our patients with HFpEF, which is, as you know, left ventricular hypertrophy, impaired relaxation, and diastolic dysfunction. So then we wanted to see whether we could use this platform to interrogate the effects of SGLT2 inhibitor. As you know, SGLT2 inhibitor, the anti-diabetic drugs, has shown to have cardiovascular benefits primarily on heart function and reducing heart failure hospitalization. And it's not clear whether these are systemic effects or direct myocardial effects. So we wanted to see whether we could see any effects with empagliflozin on our iPSC cardiomyocytes and whether it could correct the abnormalities we see in our HFpEF cells. So we use these iPSC cardiomyocytes, we treated them with empagliflozin, we use 1 micromole, which is a dose which is on the low range, so we have less off-target effects. And then we looked at cellular hypertrophy, calcium mishandling, contractile impairment, and metabolic abnormalities. And so this is the initial data. We found that empagliflozin treatment was not able to regress or affect the cellular hypertrophy, but it did have an effect in improving the calcium transient as well as the impaired relaxation we see in our iPSC cardiomyocytes. And so there seems to be an effect of the EMPA directly on the cardiomyocytes, and it's mainly a functional effect rather than a structural effect. So it cannot reverse the left ventricular hypertrophy, but it can improve calcium transients and function. We then looked at metabolism. So these are the data without empagliflozin first, just showing that there is reduced ATP levels in diabetic and diabetic heart failure iPSC cardiomyocytes. You can see both of them have reduced ATP, but interestingly, the mitochondrial respiration was not different between the healthies and the diabetic heart failure. And when we gave EMPA treatment, we found that EMPA didn't have an effect on the mitochondrial respiration, but was able to increase the ATP levels in our iPSC cardiomyocytes. And then we looked at the metabolomics in our HFpEF cardiomyocytes, and we found that the diabetic and diabetic heart failure cardiomyocytes have elevated both medium and long-chain acyl-carnitines. And one particular interesting finding was that the pyruvate levels were markedly increased in the diabetes and diabetes heart failure. This is interesting because if you remember the study in 2023 by David Cass and the team, they looked at metabolomics in human heart tissue samples from HFpEF patients, and they too found that pyruvate levels were elevated. So it seems that in a dish, we're able to recapitulate some of the metabolic defects seen in actual human heart tissue from HFpEF patients. So we looked at the effect of EMPA on metabolomics, and we found no direct effect of EMPA on fatty acid metabolism. but we did find that it was able to restore the pyruvate levels. So the high pyruvate levels that we saw in the diabetic heart failure cardiomyocytes were restored by the empagliflozin. So how would it do this? So we were hypothesizing that it could be to do with the mitochondrial pyruvate carrier that brings in pyruvate into the mitochondria, and whether there was a blockage here and EMPA was able to restore this. Importantly, if you have the blockage here, then this could lead to the buildup of glycolytic intermediates that can be toxic to heart function. So we looked at this pathway, and we found that empagliflozin was able to increase the expression of mitochondrial pyruvate carriers, 1 and 2, and we think, and work is ongoing now, we believe that this is, by doing this, it can relieve this obstruction at the level of pyruvate going into the mitochondria, and this is the way it can restore energetics in EMPA. Now, of course, there's always this debate about whether the effects of EMPA at the organ level are through the SGLT2 receptor. We know that SGLT2 receptors may or may not be present in the heart. Some studies suggest it's present in the heart, which is diseased heart, but not present in normal heart tissue. So we wanted to see whether if we knock out SGLT2 in our iPSC cardiomyocytes, do we affect or do we block the EMPA effects? And interestingly, we found that when we use siRNA to knock out SGLT2 in our iPSC cardiomyocytes, we still see the beneficial effect of EMPA. So at least in this model, it would suggest that EMPA doesn't go through the SGLT2 receptor. Similarly, this is that data. siRNA knockdown of the SGLT2 does not block the effects of EMPA. And in this study, we did siRNA knockdown of SGLT2 to see if we got beneficial effects in our disease cells, and we didn't see that. So it seems then that, at least in this model, empagliflozin doesn't appear to go through the SGLT2 receptor. We don't know which receptor it is or whether it needs a receptor. There's emerging data suggesting that SGLT2 inhibitors can go into the cell and maybe have their effects there. So just to finish off, this is the Prevent Heart Failure platform. This is something we set up in Singapore, where we're able to model different cardiac disease and use this as a platform for drug discovery. We are planning now to test engineered heart tissue as well as cardiac organoids using our iPSC derived from the patients to see if we have a phenotype, and then we believe this will provide much more realistic modeling of HFpEF, and we can do omics and single-cell omics on this to find new targets or treatments for HFpEF. And of course, we link to the animal models here. Primarily, these animal models are going to be used for PD or PK. Similarly, we are now looking to model HFpEF away from the 2D platforms to actually engineered heart tissue and cardiac organoids. And we're also working with a company called Nova Heart to make this heart in a jar, which allows you to measure contraction and relaxation using pressure volume loops in the jar. It's more for disease modeling, it's not for regenerative therapy. So finally, I'd like to thank you for your attention. What we've shown here is that we can use iPSCs to model HOCM to find a potential new treatment target. This could be inhibiting fission for metabolism. And we show for the first time that we can model diabetes HFpEF using our iPSC platform. This can be used for target discovery, but also can be used to screen current therapies that we give. So it'll be interesting to see vericiguat or GLP-1 agonists using this platform to see if there's any direct cardiac effects. Finally, I'd like to thank you for your attention, and of course to thank the fellows and our funders. Thank you very much.